Okay, kia ora koutou, everyone, and welcome back to this series of presentations. My name is Laura Wilkinson-Myers, and I'm the Vice President of the Health Services Association of Australia and New Zealand, and I'm based in Auckland at the School of Population Health. Just a reminder, if anyone is just joining us right now, we're doing presentations of about 7 minutes in length with 3 minutes for questions, and you'll hear a little bell from my colleague Tilly as we reach, thank you Tilly, as we reach the 1 minute countdown point for your talk. And I'd also like to please encourage you to put any questions in the Q&A section down at the bottom of your screen. I will definitely be keeping an eye out on those for those 3 minute question sessions. To kick us off, I'd like to welcome Gang Chen, Associate Professor from Monash University, who will be talking about changes in public preferences for technology-enhanced surveillance following COVID-19. And welcome.
Thanks, Laura. And good morning and good afternoon, everyone. Firstly, on behalf of all co-authors, we are very grateful to having this opportunity to present today. Okay, I try. Globally, since the outbreak of COVID-19, different technologies have been used to facilitate rapid case identification and contact tracing. These are vital tools to control the spread of virus and to reduce the potential negative impact. But meanwhile, there is evidence indicating that these technologies may lead to significant risks to personal privacy and may be open to misuse. During the current COVID-19 pandemic, we see more debates on this issue of having, for example, COVID-19 surveillance in the society. I think one of our key contributions to the literature is to explore the general public's preference for the use of new technologies for enhanced infectious disease surveillance in Australia. And in particular, the timing of our survey allows us to explore whether the preference will change owing to the COVID-19 outbreak. So 7 attributes were used in our discrete trial experiment. To attain these attributes, a few steps were followed. Back in 2018, a few literature reviews was conducted, and the consultations within the research team across our extended expert networks, including the CRE, were conducted, as well as our team's Delphi study. So in brief, at the end, the 7 attributes were selected to be included. Those are personal autonomy, the privacy, the data certainty, mortality and mobility prevention, as well as attribution of responsibilities. An example of a DCE choice task is shown in this slide. So respondents were asked to choose one of their preferred surveillance program from 2 hypothetical programs. Then they were asked whether or not they will participate in the surveillance program that they have preferred before. So the second stage choice test will help us elicit unconditional preference and will be relevant if the surveillance program is non-mandatory. So that's on the screen shows. We initiate the data collection in late November 2019. And to ensure that the survey was running as intended, we informed the panel company at the beginning of the study that we would like to review the data approximately halfway through the recruitment. So this figure basically shows the timing of our survey more clearly along with the COVID-19 outbreak timeline. So the 2 gray periods are our data collection time. And we stopped in early January, and later on the first case being identified in Australia is late January, and then we started our data collection again in early February and finished at the end of February 2020. So a total of 2008 respondents included in the main analysis. Respondents are largely representative with regarding to the demographic, but with slightly higher socioeconomic status such as education level. What we are more interested is to see whether there are differences between the two subgroups prior and the post-COVID-19 onset, and there were no statistical difference on those individual characteristics. So today I'm going to present some key results from the false choice task, which was estimated to use a mixed logic model. So here is a summary of the findings. On this graph on the left are those results coming from the pre-COVID-19, and to the right are the post-COVID-19 outbreak. So the effects coding were used such that all the coefficients for all the attributes are presented in this graph. Briefly, I guess we can see that the pattern are quite similar pre and post. There are some similarity. For example, within each subsample, mortality and mobility prevention are two most important attributes. And then on the other hand, personal autonomy is the least important one. But meanwhile, this attribute is probably the most clear one that we can see the difference during the pre and during the post time period. So on average, respondents significantly preferred a surveillance program that does not restrict personal autonomy. That is to say, the person's freedom to make choices and make where they go, for example. However, it becomes insignificant post-COVID-19 outbreak. Well, another difference is that during the pre-onset period, respondents significantly prefer that outcomes of infectious disease investigation should be kept confidential and no information be made to public, while in the post-onset period, this attribute level become insignificant. So on this graph is basically this attribute, but there is a typo I just noted here. So bear in mind, there's a typo in this graph. The table here basically summarized the key results, again, from that graph, and it shows relative importance of each attribute. It basically is aligned with the graph we shown before. And we also see that during the post-COVID-19 time period, based on the modeling, that people value higher on data security, and people value more for the surveillance programs that can prevent more disease mortality and disease morbidity. So these are the key results. And to summarize, I think this study provides some evidence that public acceptance of technology-based infectious disease surveillance is situation dependent. During the pandemic, there is likely to be some tolerance about a system that results in restrictions on personal activities. But meanwhile, respondents value more on the surveillance systems that has higher data security and can be more effectively prevent mortality and morbidity. This study provides a unique insight into how much attitude changed in light of the significant and evolving disease threat and shifting policy context. I would like to finally thank the funding source we received, and we are really grateful to our respondents for their time and the effort. So more details from the study, it has just been published in BMJ Open in late November, so more details will be there. Thank you so much for your attention. Thank you.
Thank you very much, Gang. We have quite a few questions cropping up related to your presentation, and we've got just a couple of minutes left for them. I've got one question of clarification, and can you speak to what the attribute levels for, what were the attribute levels for responsibility?
Yes, so for the attribute levels for responsibility, okay, sorry, I tried to move my slides, but it's somehow frozen. Oops. So there are 3 levels we considered. And the first one is that, all right, I cannot see my clearly, I'm not sure why.
Sorry, Gang, I think we may have taken control from your slides and given the control to the next presenter. Okay, you've got it back now.
Okay, thank you. So we have 3 levels. The one is all make to the public. So it's a bit tricky for me to control. I might just say that we got 3 levels. It's all make to the public. The second one is to keep confidential unless there is a risk remains for the public. And the third one is kept confidential. No information is made to the public. So among the respondents, all made to the public will be the least preferred one. And the highest preferred one will be kept confidential unless there is a risk remains for the public. And the middle one is keep confidential, no information is made to the public. But this level become insignificant during the post-COVID-19 period, outbreak period.
Thank you very much, Kang. I think what I'll do is I'll try and grab some of these questions and collect them for you to follow up on. Thank you. Okay, and Sarah, we'll just go on to the next presentation. I'd like to welcome Deborah Street, professor from the Center for Health Economics, Research and Evaluation at the University of Technology, Sydney.
Right, thank you, Laura, and thank you all for coming.
Deborah, you're on mute, I think. We can't hear you. Can you just have a look for your microphone icon?
Unmute. Is that better?
Yes, thank you.
Yes, sorry about that. I thought I'd unmuted. Okay, so who gets the last bed in a pandemic? That's what we're interested in. And my co-authors are intensivists at the Prince of Wales Hospital. So how do I move on, Sarah?
You just need to click the first screen twice. And that, thank you.
Okay, right. Thank you. So we asked respondents to imagine that they were lay members of the hospital's triage committee and that they were in the midst of a pandemic, that the hospital's ICU was full, surge capacity was full, operating theatre working as an intensive care unit was full. All hospitals in the state were in the same situation. They had 2 patients deteriorating on stretchers in a corridor outside ED. They've been reviewed and likely die if not admitted to ICU. And then they were asked which patient they would recommend the final ICU bed to. The introduction, as an introduction to this talk, the Australian and New Zealand Intensive Care Society has guiding principles for complex decision making. And they advise that patients be assessed by 2 intensivists who should first consider likelihood of surviving, taking account of the acute illness severity, comorbidities, and the likelihood of long-term survival. And if these are equal, think about age, membership of disadvantaged group, caring responsibilities, and whether or not people are frontline healthcare workers. And don't think about things like disability, religion, wealth, race, etc. So our aim was to compare these guidelines with what the general population does when asked to make choices in this setting. Here's an example of a choice set as it was shown on the screen. We presented 2 patients and 5 attributes: age, occupational health prior to the pandemic, and the chance of surviving if admitted to ICU. We also asked respondents whether they felt that tossing a coin would have been a fair allocation strategy. We presumed that tossing a coin would be favoured when patients were perceived to be equally deserving. We don't actually know that that was the situation. We also collected some demographic information about respondents in case that helped us explain how people were making decisions. I talk here about a latent class model with 3 classes that we fit in. The line indicates that that particular variable isn't useful. So a negative contribution to utility means that a patient with for instance, a prognosis of 5%, really decrease the chance of being chosen for individuals who are in, for some individuals, those we call class 1. you can see that caring responsibilities were important in classes 1 and 2. You can see that class 3, which represents these people that are hovering around 0, aren't really using any of this information to make a decision on who should be allocated the final bed. So to summarise that, classes 1 and 2 represented about 2/3 of our respondents, a higher chance of surviving until hospital discharge, a younger age, a better health state prior to contracting COVID, and being carers were all characteristics that increase the likelihood of a patient being allocated the final bed. And for the class 2 respondents, which is 41% of the total respondents, being a frontline healthcare worker was also something that was important to them. For the class 3 respondents, none of the characteristics that we presented helped them decide which patient should be allocated to the final bed. So how do these results compare with the guidelines? Well, the guidelines are saying prognosis and health bias should be the first 2 attributes to consider. And that's similar to what those in class 1 are doing. Then you can consider age, caring status, and being a frontline healthcare worker. And that's tended to be what was going on in classes 1 and 2. But those in class 2 particularly strongly favoured younger patients, and caring responsibilities are more important to the population than they appear to be in the guidelines. Limitations: it's difficult to get a really accurate estimate of probability of survival to hospital discharge, so that may have some bearing on what's going on. And decision making on a screen is much more abstract than knowing that this decision may affect people's lives, and possibly that means people make different decisions, and it may be that people who are currently in class 3 would behave differently in a real life setting. So thanks to the Prince of Wales Hospital Intensive Care Unit Trust Fund for making the data collection possible, to my colleagues in the DCE group at Share for helpful feedback on the penultimate version, to the respondents who took the time to complete the survey, and thank you for listening to this presentation.
Thank you very much, Deborah. I'll just checking the Q&A. I have one question about how the respondents were recruited.
We used Survey Engine provided the, we ran the survey on Survey Engine, and they came from Tuluna, which is an online market research panel. And they were chosen to be representative of the Australian population in terms of both age and sex.
Thank you for that, Deborah.
Mm-hmm.
Just check. Rachel has a question. There's a general preference for saving the young. Do you think there was any consideration of capacity to benefit? E.g., young people may still survive without an ICU bed.
We set it up to say that they would likely die without an ICU bed. So that wasn't relevant in this case because that was what it was. You know, that's how it was set up.
Thank you, Deborah. I just had one, I don't think there is someone else on the list, but I just had one interesting comment question, and that was the fact that you compared what the professional society's principles were with what the patient's preferences were, which I thought was really interesting, that they were sort of echoing one another. And does that say something about actually involving patient groups in those committees in the first place? Is that
Well, the interesting situation then, if you had patients in such a triage committee, is that you'd be asking for a 24/7 triage committee with lay membership. Possibly not practical, but
right. I understand.
Yeah, a better context than asking people to imagine they worked in ICU, which I don't think anyone who hasn't can do.
Right. Thank you very much, Deborah.
Thank you, Deborah.
All right, we'll just, all right, I'll just go and set up our next speaker. So now we have Kathleen Manipis, a PhD student and research fellow from the Center for Health Economics Research and Evaluation at the University of Technology, Sydney. Welcome, Kathleen. And I've just got you on mute.
Sorry, I'm trying to put my camera on and it does not seem to want to go on. Start video, here it is. Okay, thank you.
Lovely, thank you.
Thanks, Laura. Thanks for coming today. Today I'm presenting a DCE that explores the trade-offs between economic and health outcomes during a pandemic, and this work is part of my PhD. Oh, sorry, can I go back? Okay. So this research was motivated by the COVID pandemic we all experienced this year. We're all familiar with some of the measures used to control COVID-19, such as social distancing, quarantine and isolation. We were interested in measuring the trade-off between disease containment, economic sustainability and social disruption. At the start of the COVID crisis, there were headlines that were dominating the news, which centred on balancing a trade-off between the economic costs of lockdown and saving lives. We used a discrete choice experiment to examine the relationship between health risk and productivity at a national level. And we wanted to understand what control measures and outcomes are acceptable to citizens when considering the health risks, freedom and job loss. So on the right of this slide, you can see the attributes included on this DCE. We selected 8 attributes based on 3 main themes. So the control measures covered 3 attributes with the restriction level, duration of the restrictions and tracking. Burden of disease was comprised of two attributes, so total number of infections and the total number of deaths. And economic consequences included total numbers of job loss, total government spend and income tax levy. Restrictions described in the survey were based on those that occurred at different stages of the pandemic. So we showed respondents this image to explain what the levels of the control measures in this study meant. The characteristics we used to describe the restrictions in this study focused on aspects that holistically result in changes in productivity, such as quarantine, isolation, staying at home, and the effect on offices, schools, and stores and services. On this slide is an example of what a choice set looks like. We asked respondents to complete 8 of these choice sets where we varied the levels for each choice set, and we asked them to choose which policy they preferred given the 8 attributes that were presented. We recruited respondents via an online panel, and data were collected over July and August, and it was during the time that restrictions in Victoria were changing. In our sample, we applied quotas by age, gender, and state of residence. And we applied the state of residence quotas such that at least 300 people from New South Wales were recruited, 300 from Victoria, and 300 from other states and territories were recruited and included in our sample. In our sample, 60% of respondents reported they were employed, about 3/4 reported they lived with others in the household, 1/3 reported they had some illness, health problem or disability, and about 40% had downloaded the COVID Safe app. These are the results of the mixed logit model. On this graph, the red line represents 0. So any of the results to the right of the red line shows that respondents prefer this attribute level compared with the base. Anything to the left of the red line shows that respondents have a preference against this attribute level compared with the base. So for instance, if we have a look at deaths, and we have a look in particular the level of 5,000 deaths, what we see is that respondents have a strong aversion to choosing policies that result in 5,000 deaths compared with 1,000 deaths. Results that don't cross the red line are statistically significant relative to the base. Now, also on this graph, what you can see is that the coefficients for infections, deaths, jobs lost, government spend, and tax levy are also to the left, showing that respondents have an aversion to these particular levels. In particular, they have preferences against a higher burden of illness and higher economic consequences. And all of these coefficients for these attribute levels were statistically significant compared with the base levels. Under the control measures theme, you can see that the restriction levels for level B and level C were not statistically significant, neither is the 3-month duration of restrictions. But what you do notice is that as the time increases, so as the time of restrictions being implemented for 6 months and 12 months increase, respondents prefer that this don't like when the duration of restrictions are increased. Also of interest is the tracking attribute that we had used. So what you can see is that the results are to the right of the red line, indicating that respondents prefer that people are tracked with a mobile phone compared with no tracking, and people that are new arrivals or positive cases are tracked with a tracking bracelet compared with no tracking being used. We also did a latent class analysis, which divides the sample into groups based on their choices. And from the latent class analysis, 2 distinct groups or classes were identified. So what you can see is in class 1, people in this group do not have any strong preferences because most of the results hover around the red line. Class 1 had a small but statistically significant preference for level B restrictions and use of a tracking bracelet. And class 2 are more similar to the mixed logit results, where their preferences are driven strongly by the number of deaths comparatively to all the other attributes presented. So class 1 are likely to include younger people under the age of 34 and rate their health as excellent, whereas class 2 are more likely to include older respondents over the age of 45 and rate their health as poor. So the impacts of the COVID pandemic have been broad. The productivity impacts also affect people who are healthy, and healthy people still need to comply with the measures. In our study, we've observed stronger preferences against high mortality compared to high levels of job loss. And although there are suggestions in the media that the community finds the impact of restrictions unacceptable, in this study, more restrictions did not necessarily translate into less acceptance. The levels of restriction had varied across Australia during our data collection period because there was a second wave that was unfolding in Victoria. So in this study, we have a mix of respondents where the described scenarios were more hypothetical in some states compared with other states. But overall, the results broadly suggest the Australian public are supportive of the measures. Thank you for your time listening to this presentation, and I'd like to thank the DCE group at SHARE, people who completed the survey, and the Australian Government Research Training Program. Thank you.
Thank you very much, Kathleen. Well, I have a question, but I'll go with Rachel's question first. Will your research influence policy?
I'm not sure. I thought it was interesting that people did prefer tracking. So in a way, it showed that they were willing to give up some freedom, and they saw that, I think they kind of thought that perhaps the restrictions had some sort of protective effect. So it's kind of nice to know that people in Australia were accepting that restrictions were important, and it was a way to minimise morbidity and mortality. So that's promising. I'm not sure if it will change policy, but I certainly find it interesting what's come out of this study.
Thank you. I've got another one. Do you think government spend is an accessible value for general public to understand? And could you consider a per person spend?
We did consider a per person spend. I suppose the reason why we went with an overall government spend was, one, we wanted to use a national perspective, and two, in the media there was a lot of discussion about the $130 billion JobKeeper spend, and then there was a mistake of a $60 billion discrepancy, and we kind of thought that because there was so much media coverage around it, people would have an understanding about the government spend at that level, or have some sense of it.
Thank you, Kathleen. I think we've got maybe time for another question. Are there any differences between states that you found?
So I've run a conditional logit model using different subgroups for Victoria, New South Wales and other states and territories. And the pattern of the forest plot are basically overlapping. So to me, that shows that it was similar all across Australia, but I didn't see any real differences that were significant between the different states or
Thank
regions
you.
that I put in.
Thanks. I'll squeeze one last one in. Are you aware of any similar studies that have been conducted in other countries with a different pandemic experience?
Yeah, there was one that I saw that was published, and that was published by, I think it was Duke University, and it was an American study, and they had 4 different attributes, and theirs was more tailored towards opening of the economy. So they didn't actually include death in there or government spend, so they had only 4 different attributes. It was interesting what they pulled out, and they showed that there were differences down the political line, which I thought was interesting because I didn't understand how you had to register as a Democrat or Republican in the US before voting. I didn't understand their voting system, but that was interesting, some of the things they had done. I think it was Shelby Reid was the author of that paper.
Thank you very much, Kathleen. Thank you for that presentation. I'm now going to turn to our final speaker in the Discrete Choice and Preference Studies section, Associate Professor Lisa Hall from the University of Queensland. Welcome, Lisa.
Thanks, Laura, and just really emphasising what an interesting session it's been this morning. So congrats to HSRAANZ for pulling this together. It's been a long year, but it's nice for us to regroup as a community. So just today, giving you a brief update on some work that we've been doing on low-risk febrile neutropenia. And this really came about from a large scale-up project that was already underway with MRFF funding when the pandemic hit. So the work's led by Gab Hausler, who's based in Melbourne at the Royal Children's, and it's coordinated by Mariana Banevsky at Murdoch Children's Research Institute. So a shout out to them in particular. And this work was led by myself and Gab and Richard Deborah Florenko. So acknowledgements out of the way, let's get into the talk. Oh no, I'm not.
Did you just double click the screen?
I did. Here we go. And it just went out of full screen mode. Oh no.
Just try again, Lisa.
Oh, here we go. Double click. There we go. Great. Thank you. Oh, it's amazing. You can teach all year online, and when you come to do a conference presentation, everything changes. Okay, so just as a bit of a background, because most people online won't be clinicians. So we're talking cancer kids here, and for a kid being treated with cancer, fever and neutropenia, which are the most common causes of ED presentation and unplanned hospital admission. And we're really on the lookout to try and prevent sepsis because kids can go downhill very, very quickly. However, we've always tended to err on the side of caution and keep kids in hospital for long periods of time, even if they've got very few symptoms. But in recent years, there's been a real push to look at trying to identify which kids are low risk for progression of their febrile neutropenia and managing those through home-based management. And we know from previous studies that home-based management of low-risk FN and a structured program is safe, improves the quality of life, decreases length of stay, and reduces healthcare expenditure. So here's the typical febrile neutropenia journey through our low-risk pathway. So it's not just a clinician judgment whether a kid is low risk or not. We actually have a full validated clinical decision tool that includes rapid diagnostics and examination of the absolute neutrophil count and actually looking at management pathways and early recognition of any complications. And it's only really at that stage where the care pathway comes into place and we put kids on the low risk pathway where they're managed more through a home-based care or hospital in the home. And the initial pilot work was done through the Royal Children's in Melbourne, reduced length of stay, saved bed days, there weren't adverse events, and had a positive economic impact as well. So we really we're looking therefore at national scale up through our program, which is called There's No Place Like Home. So what happens when you're trying to scale up a home-based care program in the middle of a pandemic is we actually saw this as an opportunity to actually examine perceptions and the way forward. And we do actually have a proper DCE planned, but when COVID hit, we didn't have that underway. So we instead went with a semi-structured survey as a starting point. And we were looking at clinicians involved in cancer care at the trial sites, which are children's hospitals throughout the country, and also our parent advocacy network. And the things we were interested in measuring were the importance of and confidence in home-based care for cancer kids around febrile neutropenia, and also looking at their experiences during COVID. In addition to that, we included questions from a validated survey tool out of Europe called the Effective Communication Outbreak Management Tool, which really gets at risk perception and whether parents, how they would judge COVID compared to other conditions. So when we looked at our survey findings, and they were a combination of like-art questions and open-ended questions, we looked firstly at the clinicians, and the majority of clinicians did think that during a pandemic, implementing or maintaining our low-risk program was extremely important. But they brought up really good points around the need for hospital resourcing and infrastructure and needing to have a really good, solid hospital in the home service. And there was a really interesting varied confidence and awareness of the evidence behind the program. So some clinicians knew about the international research. They'd obviously been to our information sessions. Maybe these were the hospitals. We know some of these hospitals were further along in their implementation journey. And so they were the ones that were more on board and less risk averse, I suppose. But then there were some clinicians that just were, I don't even know what this would look like. Why would I put my patients on this? So, you know, we still have some way to go with some clinicians in the field. But there were some really interesting parallels between the clinicians and the parent perspectives that I'll bring up in a minute or so. This was around clinicians realizing that actually for the safety and comfort of people and patients, that sometimes it's better for people to be at home. You know, quotes like these children should be able to manage easily in the safety and comfort of their own home. We don't want them taking up valuable bed space, and a real respect for parents amongst clinicians, so that parents of high-risk patients generally have a really good insight on how sick their kids are and are able to make rational decisions. So when we looked at carers on the other side, they were keen on these programs before and after, but they also are really aware that this isn't for every kid. So they do know that it is a risk-based approach and it does depend on stability of symptoms. But if their kids don't need to be in hospital, they would rather have them at home. And I think this one here really sums it up. I feel like my child recovers more slowly when bedridden and hooked up to an IV pole. So we also, you know, as I said, looked at their risk perception around COVID, and their knowledge about COVID, and that the parents and carers had a very good knowledge of the information that was actually available publicly about COVID and the risk for their kids. And we were talking early in the first wave here, which was quite impressive. They had obviously put their focused energy into what does this mean for my child and their care. And they were actually more worried about COVID and the chance of their kid picking up COVID than having influenza or febrile neutropenia. But however, they knew if their kid was really sick, they wouldn't wait and they would bring them in. The one exception to that were parents who had probably had kids under treatment for a longer period of time and had kids maybe that were in remission, and they were much more comfortable managing symptoms themselves rather than coming into hospital and risking COVID. So I've got now here the two kind of sides of the of what parents or carers were worried about and things that they actually saw, the changes they saw and they liked. They were worried about asymptomatic carriers. They were really worried about how close the day chemo chairs were in the hospitals. Parents who, families that were from more regional areas were worried about coming into hospital with their sick kids. They were very confident in their own ability for prevention and control. They live, you know, infection control and disease prevention as their kids are undergoing chemo. That's their life, right? But they don't see others doing the same. So they were more worried about other people not undertaking those preventive measures. One thing that I thought was really interesting is that they realized that their kids were having to be screened for COVID very frequently while they were in hospital, and that was causing quite a bit of distress. And they were also worried then when there was only one carer being allowed, and that was a big burden on that one parent or carer, rather than maybe having when there were two carers potentially being able to share when a kid was in hospital. They liked telehealth. They liked the fact that there weren't a whole lot of visitors and siblings, particularly in day chemo, hanging around. They thought that was much more calming. And they also liked the fact that there was better communication between departments. So just as a final wrap up, here's just a big thank you to all of our hospitals that are taking part in the Scale Up program. Our website's there if people are interested in looking in more detail. And we've just had a paper with the quantitative results and the qualitative findings accepted for publication in Journal of Pediatrics and Child Health. Thanks.
Thank you so much, Lisa. We've just come to time for this particular session, so we might gather some questions for you over the break, but a really nice piece of work, and really appreciate your presentation.
Thanks.
Thank you, everyone. So we'll just be taking another 10-minute break now, and when we come back, we'll be looking at models of care and genomics.